Oh, I'm so delighted to be here today. Let me just check my voice. Can people hear me in the back? Were y'all all right? Good. I'm new to Nashville. I've been here about a little over a year, about 14 months. I have driven by this establishment, and when I was asking where I came today, I kept saying, but where in this wonderful campus was I to come? And not knowing what to expect, I imagined 5 people, 10 people, maybe. And so I'm very, very happy to be able to talk to all of you about one of the areas of genetics that has expanded, grown, exploded, and actually changed our lives. I'm a lucky person in that I actually like what I do. I love what I do. But I also started my training as an internist when genetics was just getting off the ground. We just were starting to understand some of the impact of genes and genetics. And so I have just been not only a worker, but a passenger kind of watching all of these changes. So what I wanted to share with you today was some of the things that are new, some of the things that you can think about. It's also to let you know about a new program that I was invited to come start at Vanderbilt, which has this impossible name, Clinical and Translational Hereditary Cancer Program. And I'll talk about that a little bit at the end. Please, unless you have a real burning question, save your questions towards the end. I might, sorry. I might be able to answer what you're thinking, and then we can have more of a discussion, which I'm sure you'll find I love to do. So again, this is my area that I find most interesting. One of the facts I want to start out with is that cancer itself is a genetic disease. And then what we're going to talk about is what does genetic mean, and how does that differ from hereditary? So I just want those concepts out for you right now. So tumors start by a number of factors. They don't just start out of whole cloth. They don't jump in, excuse me very much. They just don't start immediately. There's a process, and we'll talk a little bit about that. But it is the combined effect of genes, outside factors that are important for cancers. And this will be important for picking your parents, which we started off with. As we think about these factors, just remember, cancer is a disease of the genome, and we'll get to that again. I bet many of you people know this person. She's been in the news lately. She's a well-known actress. This is Angelina Jolie, and this is a picture taken from Time magazine where they were discussing her process and essentially her conversation that she had with the nation about undergoing genetic testing for a very strong gene that causes breast and ovarian cancer, and we'll talk about that gene later. But she made some decisions. She made health decisions. She was empowered by that process, and she actually then talked about what that meant for her. I bet you can imagine that our phone lines lit up after this discussion. And while I'm very thankful to her, I think there was a lot of confusion that came out of that, and I'm going to address some of the subtleties that people need to think about. So you all know that cancer is one of the deadliest forms of disease we have in America. It's the second most common killer after heart disease. It is really resistant to some of the changes and some of the therapies that we have. And so there's been a lot of information and a lot of research focused on cancer. And so what I have here is 2 examples of common cancers. One you can see that's on my right, your left, is the inside of a colon. And it actually shows how a polyp grows into a cancerous lesion, into a tumor. And then the other one is the slice of a breast tissue that shows cancer starting in the ductwork and how that goes through a progression. into cancer. So remember at the beginning I said cancer just doesn't occur by itself. It doesn't come out of whole cloth. There's a transition that happens, and a progress, and this idea of transformation. So we have an idea of benign disease to cancerous disease. Benign disease doesn't go anywhere, doesn't travel, usually does not kill people. Malignant disease does travel and can shorten a person's life. So that's why we're so respectful of cancer. We don't like it. We have to have therapy for it, but it also can shorten people's lives. So that's why we're so concerned about it. But it is common. What is uncommon, though, is the hereditary forms, and I'll get to that in a little bit. So I also said that cancer is a disease of the genes. And I'm going to use a term, and I'm going to define it now and define it a little bit later, called genome. The genome, all of our genes that we carry with us, the entire set. And right now, we think that's about 22,000 genes amongst our 23 sets of chromosomes. So that's a fair number of genes. But what happens in cancer is that there's an effect where there's a error, change, alteration, mutation. These are all words that we use when we're talking about the disease process in cancer. There's this mutation that is in the tumor. And that mutation allows the cancer cell, or that benign to malignant transformation, allows that cell to grow. And in essence, it gives it more powers than a benign cell has. Powers like what? Being able to grow a little faster than its neighbors, be able to use all of the resources around it better than its neighbors, and then also the ability to pick up from where it was and travel to another part of the body. Those are all things that happen in malignancy, and they're genetically based. So just think of the cancer cell as having a disease of the genome, a disease of the genetics. But I want to point out, and let me see if I can actually bring my pointer. I'm not doing this so well, am I? Right here. Germline. Germline is the concept of genes that are given to you by your parents. And the germline can be very important because it can give a person genes that are cancer fighters. Can also give a person genes that are very susceptible to the cancer process. So a person's own constitutional genetics is really important in this process. And we'll talk about this a little bit later. One of the other facts that we've learned about cancer and what's been very important at the Vanderbilt Cancer Center is this idea that not all cancers are created equal, that the genetic forms will give an idea of how those cancers are going to be treated. And this is just a cartoon from the National Cancer Institute that just says that there's different types of cancers, different types of therapy, and now, based on the cancer genome, hopefully there's better therapies. But there's some people that can, lead exemplary lives. I've had women who've come in who've had breast cancer, and they've said, I have never done anything in my life that would cause cancer. I'm a runner. I eat well. I've never smoked. I don't drink. I've never even jaywalked. Why would this happen to me? And this is an example here of lung cancer. Here's a man over on the other side who has normal cancer cells in his lung, and he's a smoker and he's a drinker. And there's another person over here, never has done any of those things, and has a serious cancer of the lung. Well, we think what is going on is that there are the constitutional genes that a person is born with, plus the molecular subtype of those particular cancers. And a lot of that, unfortunately, is luck of the draw. But with now new scientific focus on these molecular subtypes, what doctors can do is they actually give medicines that are focused towards that type of cancer. And I think that's a very, very exciting thing that's happened now. Okay, so we're going to start talking about some definitions. Definitions I know are really, it makes you think about back to high school and your genetics and your pea plants. And let me tell you, this is not the type of genetics we're talking about. So we talked about genome, all of our genes, but we didn't say what a gene was. So if we go back to Mendel and Mendel's peas and the idea of heredity, the gene was the unit of heredity. Okay, they didn't have the microscope, they didn't know about chromosomes, they didn't have all of the molecular kind of analysis we can do now, so they didn't know and they couldn't say what a gene was. Well, we've gone from that idea of unit of heredity down to actually borders of genes, structure of genes, where those genes are. So we have a lot more information about the genes. But we know that genes are important because they interact with our environment. So it is a very active, vibrant, dynamic part of our bodies. One of the things that was a big surprise in the Human Genome Project, and that Human Genome Project was sequencing all of the genes that made and encoded proteins in the body. That's the 22,000 genes or so that they needed to find. That particular set of genes gave us a surprise. And one of the surprises was that there was a lot of dynamic changes in our genome, a lot of dynamic changes in the genetic code. That was number one. The other part was that there was a great deal of variation in the genetic code. So for example, for any given gene, there could be different sequences or different ways to code the gene that still resulted in the same product. So the gene works the same no matter if it's one way or the other. And my favorite example of this is brown eyes and blue eyes. Brown eyes and blue eyes see just the same. There's no changes in how they work, but we can tell the difference. We can see the difference in those two. And so that's a natural part of variation. And we all have that. So that was one of the big, big, big surprises. The other surprise was how alike we are, in that there's this variation. But still, amongst all people, all races, all ethnic groups, the genetic code is the genetic code. So there's nothing really different that's going to say that I'm from, I'm going to say Scottish, Irish, English, Welsh, mongrel stock that would identify me specifically as that group. And so that's important to know. But there's some differences. So your genetic code, though, can be kind of an identifier. By what that sequence is, might be even unique to you. And that's another big surprise that we had, is that we could actually use that to identify people. So variation is a fact. It's very important for us to know. I think it gives us some robustness to the species. It's important for us to be a strong biological species. But what we know is that sometimes these changes can cause differences in how we think, how we behave, and even our risk for cancer. So that's actually key. Some of the changes are modest. They really don't change very much. They give us very, very minor changes, and those are ones that we also know can happen in cancer. But some of them are big, and that's when we use the term mutation. A mutation does not mean mutant. People don't like the word mutation. Does not mean mutant. It means that there is a change in the genetic code that causes an effect in the gene. It disrupts the gene. It changes the way it's supposed to work from its normal function. And it's not just in cancer genetics, but this is in all forms of the effect of genes on the body. So the way we grow up, or the way we metabolize glucose, or any number of the diseases that some of us are prone to. So big changes are those mutations. So this is an artist's rendering of a cell, and out of the cells come in a chromosome. So up in here is the cell inside, that's the nucleus. I bet you never thought you'd be thinking about cells and nucleuses again. But it's exciting stuff. Here's the chromosome, and they are structures And they think of them as organizational tools, or how the genes are organized. They're organized and then able to work from that point. And then if we would actually take that chromosome and just start pulling it until you got the full length, what you would actually be able to see is this molecule here. This is the double helix. And it's made of 2 strands of DNA that kind of wrap around each other. And it's a marvel of construction. But when we talk about mutations, we are talking about in the DNA strand. Those are the keys that for us. So a mutation, here we are in the DNA strand again, the double helix. And there's a big star, which is an artist's rendering for a mutation. And there's many, many, many types, but they all occur on the DNA level. So it's important for us to know. Then we can go back to the idea of cancer is a genetic disease. There are mutations in important genes. And I gave you an example, the Angelina Jolie example, that in BRCA1 and 2, there's over 5,000 separate mutations that have been reported. And counting. So it's something that's for the laboratory is important. So there's lots of mutations that can be found. But there's many, many different types of genetic disorders. And I want to back up a little bit before we jump back into specific genetic disorders for cancer. I want to jump back a little bit and just kind of go over the types of disorders that we can think about having, because genetic alterations are part of our lives, and we know of these as part of our lives, and I bet you'll even recognize them. But in general, remember I showed you the chromosome. You can actually alter the chromosome. You can break it. It could be made in different ways. You can have a DNA-based, right at the gene level mutation, so that's called single gene. Or you can have multifactorial complex disorders where you have many genes, or you have genes and environment. That's where most of our disorders come from. So that's a big, big, big group, one that scientists are just teasing out. And then you can have acquired mutations that occur just in the cell. And it's the cell that becomes the problem. And this is where cancer starts, this acquired somatic mutations. So when I went to genetic school, this was kind of the list of things that we would always think about where those disorders would be. So we use some tools, and then notice that there's some things about the family that's important for us to think about. How do we tease those apart? But there's some steps that we learn to go through, and those are important principles. But here's a genetic disease, and it's an example of the chromosomal type that I know you all are familiar with. And this is a picture of a little guy with Down syndrome. And if you notice all of those words around it, it's kind of a word cloud of all of the types of things that can happen with somebody with Down syndrome. Primarily growth failure, they don't get very big. They don't have this cognitive issues, so they're mentally retarded in many cases, and then they have some physical features that can be seen. But it really comes from the fact that they have an extra chromosome 21. Researchers are still trying to figure out why 21, what happens with 21, and really what we know is that this happens with a certain frequency in the population, and we actually know what the result is. But this is an example of, you all know genetic diseases. This is a genetic disease. It is typically not heritable. It happens in the course of developing that child. So I also said that the multifactorial group was one of our biggest groups. I kind of want to go over my chart here a little bit. Because I think it's important for us to kind of think about. So if we I'm having a hard time with there it is. Single gene chromosomal is right in here. And I've tried to color code this so you could see the relative amounts of genes and environment. And so in this one, it's mostly genetic, so it's mostly green with just a little bit of environment occurring. Environment can be almost anything, so just think broadly about that. And then over on the other side, environmental causes, environmental diseases, like infections or trauma or those sorts of things, don't have a whole lot of genetic component to it. But it's this middle group again, I've lost my pointer. Okay. The middle group, that is a lot of blue and a lot of green. It's that mixture. So it's having a susceptibility and then having an environmental effect that comes along with that. So let me give you an example, again, non-cancer, of having a blood clot or a venous thromboembolism. So blood clots are things that we know can happen to you, and there's some things that we know are part of the problem. So if you go to the hospital, you have surgery, you're in bed for a while, you're at risk for having a blood clot, for example. So those are environmental, the blue causes. There's some genetic causes. They're pretty rare, and I've kind of listed them here, where you have protein C deficiency or protein S deficiency. There's a number of deficiencies that you might have. Factor V Leiden that some of you here might have even been tested for. But then if we look right in the middle, these are the ones that kind of combine those two together. So cancer can be a cause for thromboembolism. Inflammation can be a cause for thromboembolism. Having homocysteine levels that are elevated can also be a cause. And they are right smack dab in the middle between these environmental and the straight genetic forms. So geneticists working with other doctors really are trying to tease out what are the right factors, because you know if it's an environmental factor, you can modify it, you can change it, you can control it. Genes you don't get to control so much, but the environmental factors we get to do. Okay, here's an example using breast cancer, which we're going to be spending some time talking about breast cancer in the family. So there could be some environmental factors with breast cancer. Women, as they age, have a higher rate. Taking estrogen for a period of time also raises the rate for breast cancer. There's some evidence of smoking. It's not very strong. There's some evidence about alcohol intake, also not very strong. And then on the other side, there's a number of genes that we know that are associated with susceptibility for breast cancer. And these are the heritable forms, and I didn't put the whole list down, but you get the idea that there's quite a number. And then, of course, there's right in between. So we know that breast density can be, quote unquote, familial, but we don't really know what the genes are. So we don't know if it's all genetic or if it's all environmental. And then we think there's some other unknown factors. But when we think of family history, that is where we're getting our evidence, is from this combined effect of genes and environment. So I want to go back to one of the ideas that I mentioned, which is if you have a gene and a genetic mistake is underlying the cancer, it's a disease of the genome in that cancer cell. But that mutation can happen at different places and different areas. And so the example that I have just with the woman alone is a mutation that just happened in the breast cell in a gene. My example is TP53. And it caused her as part of the process of developing breast cancer. But it was just in the tumor. And then on my left, your right, the TP53 mutation is germline. That means it's in her egg cells. That means it's heritable, and it can be passed down to a son or daughter. So this is the difference between where is that mutation, what part of the body is that mutation. So if the mutation is purely somatic, it is not going to have anything to do with one's children or one's grandchildren or one's descendants. If the mutation is in the germline, it can be causing cancer for that individual, and it can be passed down to members of the family. And this is where I spend a lot of my life in talking to patients, is trying to figure out, is this an example of just happened to that person, just in the tumor, or is it in the family? Is it in that germline or constitutional DNA? Same genes, almost the same mutations. It's the place and the cell type that's important. So how do we use family history? This is one of my favorite pictures. I don't remember where I found it, but I just love this family walking on the boardwalk. with the stripes and the up and down and the little kid who's both. So this is what we think of family, right? Mom gives something, dad gives something, and it makes this wonderful child that is an expression of both mom and dad. And one of my favorite things that I get to do is listen to family stories. And I get to listen to how families work. And it's one of the pleasures and privileges that I actually have is listening to people's stories. In the back of my mind, I'm being a scientist and a doctor going, I got to figure this family out. But in the process, I get to learn so much about what people feel about family. And it's very much what I feel about my own, which is a very, very important part of our lives. When we talk about cancer, cancer genetics, and genetics in general, our feelings of family get tangled up in the science. And so it's very important that you understand what your feelings for family may be as it's reflected in your family history. And so I think that's one of the lovely parts of being a geneticist. It is, at this point, one of the single best predictors that we can have for cancer risk. Simple, cheap, and what it takes is talking to family. It takes a little bit on my end, but it's really important for you just to know what is going on in your family. And I'm glancing back and kind of guessing average ages here. You are the people who actually know about your families. And you're at a position in your lives where knowing that family tree is really important. I guess I'm going to have a show of hands. Amongst men or women, who are the ones to be most knowledgeable about their family? Is it women? Women seem to be the repository for all health whatever, and for family history. And I think that that is good, but it also lets you guys off the hook. And I want you back on the hook. I want you to know your family histories because they can be just as important for you and your offspring as the wife's family. So the way we deal with our information is different between men and women, but you really still do need to know. So if we think about a person, no other risk factors themselves, and they have a family history where there's no one with cancer in the family, then their risk is not elevated. It is the general risk. However, it doesn't mean they might not develop cancer. They're a person. So being a person, getting older is the biggest risk that we have for cancer. If we have a modest family history, then that is increased slightly. And then if we have a strong family history, and I'm going to show you one of those, the increase can be quite large. And that's where genetic testing gets involved. So why do we use family history? Well, family history has a lot of literature behind it that shows what that risk is. So it's pretty easy to go in and figure out what that level of risk is. So that's one thing. Secondly, from what I've been talking to you about, where we know that cancers and development of cancers and other diseases is a shared result of environment and genetics. That's what family history is. And why do I say that? It's a shared environment. People live in the same place, same location. They kind of have a tendency to do the same thing. Families that smoke have a tendency to smoke. People in the family smoke. People that don't smoke have a tendency not to. People that are vegetarians have a tendency to have that same diet within their family. People that love McDonald's have a tendency to like that within their family. So it's a shared exposure that you get within the family, plus they all share genes to one amount or another. So it's important for us to kind of think about that. And the reason why it's really important is, although I said we'd talk a little bit about genetic testing, and I led with Angelina Jolie, only about 5 to 10% of all cancers are going to be this heritable type, which is a small amount. Okay? Small amount. But we just need to get good at recognizing it. So here's just an example. I said there's lots of literature that talks about family history. It kind of comes like this. Here's a colon cancer example where you get 2 to 3-fold depending upon the family tree. Here's a type 2 diabetes, coronary artery disease, breast cancer, lung cancer. If you look all of the numbers, it says prevalence odds ratio. What you do is you take that number and then just multiply over the average risk. So if it says it's 4 times, if I'm reading this right, coronary artery disease, family history of that, 4 times, you take 4 times what that usual risk would be. So family history is not just in cancer, and it does follow the same rules that it does for other diseases. Okay. So when we see people in our clinic, we do spend a lot of time on family history. And so let me kind of describe this to you. The arrow is the person we're talking to. So that's just down at the bottom, and it's a 42-year-old. That's what that 42 means. And the circle means that she's a girl. So she's come in and said, my dad's side of the family has a number of cancers. Well, what are those cancers? An aunt with ovarian cancer, that's the red one. Breast cancer in a grandmother, an aunt, and a first cousin. So one of the things that we look for is, let me see if I can get my arrow back. There it is age. So DX means diagnosed. And then what we do is we compare that age to the average age. Average age for women to develop breast cancer is about 65. Okay? So we look at 40 and go, it's much younger. So if there's a shift downwards in age, that's important on a genetic level. Another thing that is important on a genetic level is just to look at the number of generations. So I'm counting 1, 2, and 3. And then thirdly, there can be a clustering of cancers. And within breast cancer, ovarian cancer is one of the most common clusters or associated type of cancers that we look for. So this is actually a concerning family history. Not very many people in it that have cancer, but it's still concerning. How many of you can just show your hands, would say, we don't have to worry because it's on daddy's side of the family? Some people think that. Physicians used to tell their patients this, even up to 10 years ago. And I'm going to tell you it's wrong. So the genes pass through moms and dads the same way. There's no difference in the genes, but it can be missed if we think, oh, it's on daddy's side of the family. And so it's distant. It's not related to me. And so that's an important misconception that we all have. Again, guys, know your family history. So here's the BRCA1 and BRCA2 genes, and they're the ones that are most strongly linked with the condition I just showed you in the family pedigree. And that condition is actually called hereditary breast ovarian syndrome. And the major genes are called breast cancer 1 and breast cancer 2, or BRCA1 or BRCA2, named only in order of being found in 1994 and 1995. So there's nothing special about those particular names. And as we think about BRCA1 and 2, I want you to kind of think about what the effect might be for individuals within the family. So here's the red flags, and some of these things we actually saw in that particular pedigree. Multiple cases of what we call early onset breast cancer, ovarian cancer, that clustering that we actually saw, breast cancer and ovarian cancer in the same woman. That wasn't in this family, but that's one of our red flags. Somebody who's had breast cancer twice, heaven forbid. People that have a different heritage, an Ashkenazi Jewish heritage, and then men that have had breast cancer. And sometimes people go, men can have breast cancer? Yes, at a very low rate. But when we see that, it could be one of those red flags for us to really think about, is it a genetic form or a hereditary form? So what do we care? Well, we care because there's such an imbalance in terms of cancer risk. And so I'll just give you some figures that are often in the literature. Breast cancer is often early age of onset and can be up to 85% over a whole lifetime. Secondary breast cancer, another breast cancer that starts again between 40 and 60%. Ovarian cancer, between 15 and about 50%. And men don't even get off easy in this. There's breast cancer, prostate cancer, and other cancers. And BRCA2 has kind of the same picture: breast, ovarian, and other cancers. So you would ordinarily say, if you couldn't do anything about this, why no? You know, if you really couldn't do anything about this, you might sit back and go, do I really want to know this? But fortunately, within the cancer fight that's gone on in this nation over the last 30 years, there are a number of things that can be done. And so we know that changing management based on genetics, based on the family history, is really key and actually can be life-saving. And so that's one of the reasons why I do this, is because I like to be able to say, you are a person through genetics and through our genetic evaluation can be one of those people that will not be diagnosed with cancer. We kind of like that. HBOC, hereditary breast ovarian cancer, is inherited as a dominant trait, and this is just a cartoon of a dominant trait. What it really means is, of the pair of genes that you have on the chromosome, so the BRCA1 happens to be on chromosome 17, of that pair of genes, they're exactly the same in men and women. So both men and women can actually carry that. And when you have your babies, you actually only give one copy of each chromosome. So that gets packaged into your egg, and then that meets with its mate, and then conception occurs, and then you go down the next line to the offspring. So when you have two, and it's only on one of those copies, there's a 50-50 chance of it going down to the next generation. And so when anyone says it's a dominant trait, everything I just told you is rolled up into that word. Now, it's sneaky, though. It is sneaky in that there's this big differential in cancer risk between men and women. Most men did not develop cancer at all, but still are carriers and can pass those down to children. Some women will never develop cancer and can pass the gene marker down onto their children as well. So that is actually called incomplete penetrance. So it's not always seen in the person that actually has it. Again, sneaky, very sneaky. The second thing is that it's possible to have a disease that is sometimes seen with that. In this example, it's a sporadic cancer that happens in the green man. Let's just imagine he had prostate cancer, which can sometimes be elevated in BRCA1 and 2, but might not have anything to do with the genetics of the family and very much just to his own aging process. And so that is something that we also have to be aware of. Not every cancer in a relative is going to be linked. And we have to tease that out as well. Again, sneaky. The other issues that can happen, as I already mentioned, is there could be a number of mutations on these genes. And what this is a diagram of both BRCA1 and BRCA2. And this is an older diagram. And all of the little dots just show where the mutations are and how many times that they've been seen. But I like to use it just to say there's a jumble. And it's very possible that a family may only have one of those mutations and there may not be another family just like them. So they may have what we call a private mutation. And so it's important for people to realize we can't always go to the literature and find out a lot about their specific mutation that may happen. And another subtlety that we always have to think about is that there are other genes besides BRCA1 and 2. I mentioned one, TP53. I had a whole list of some other ones at the beginning. But if you look at this pie graph, it's important for us to look at the sporadic, it can happen by itself, versus familial, versus those that are due to known genes. And that's the pie graph that we always see when we're talking to patients. Now, what has changed in terms of testing is that laboratories now are providing or offering tests that include BRCA1 and 2 and others. Now, they're not always the same number of genes. Some are 16 gene panels, some are 25 gene panels, some are 35 gene panels. And so when you go through testing and think about testing, you have to know what's the laboratory and what are they actually looking for and why you might do all of that, which is one of the things that is important for people as they think about this for themselves. Now, this is kind of a complicated slide. But the point of it is, there's a lot of genes, and those are all kind of in the middle. So, right in here, all of these gene names. And they are separated by risk. So, high risk, remember we talked about the risk, that odds ratio, over 5, all of these over here. Moderate risk, this whole group here. And then we are really quite not sure what this risk is. The other thing that's important is that all of these high ones, on this list, BRCA1 and 2 are here, all of these are infrequent in the population. So it's uncommon to be a carrier of a mutation in BRCA1 and 2. What happened to Angelina Jolie is really uncommon. And these genes over in here are more common in the population. So the more common it is, the less risk there may be, and it might be part of this. You need to have a number of genes, number of environmental factors for the cancer to result. Again, a little complicated, but it's the way that people are now thinking about in terms of therapy and identification of people. Okay, so enough science. What do we do when there may be a family tree? I showed you a very, very strong family tree. What do we do? So there's a number of things we have to think about. And this is what we do at my Vanderbilt Center. And so I kind of want to go through these areas. Typically, when I'm able to come out and talk to people about genetics, they've got some concerns about insurance. They have some concerns about what this means with the family. They have some concerns about how they talk to family members. And those are very, very important. So I just want to spend some few minutes on that. So testing for cancer genes that are in the germline, though constitutional genes, those specific ones need to be done in the context of a process of talking to a specialist who is actually aware of what the genes are and what the impact might be on the family. It is a blood test. It's the easiest part of it is a blood test. And I often have people saying, why can't I just come in and have a blood test? Or why can't my doctor do that? We're going to talk through some of those reasons of why it's important that you get all of the information and education that you need. So here's just kind of a list of all of the things that have to happen and that your specialist needs to be expert in order for them to be able to provide you the best care. So it is a process. So here we're back to our family. And remember, the arrows are on the person that came to me. And so she's come, and I've already told you that I think that she has a strong family tree. Okay? What I would tell her is that she is not the right person to test in the family. Okay, she's right here. She's ready to go. She's mad at me. So the reason for that is, and I've got some other slides to it, but I just want you to kind of think about this a little bit. I said that one is, let's just imagine, if her dad is a carrier, and he could not have disease, but he could be a carrier. If he's a carrier, her chance of having that mutation is half. And I've also told you that there's lots and lots and lots of mutations. So when you go through testing in this situation, and if there's a mutation, I already know she can't have a higher risk than a half. I already know that. And what I want to do is make a negative test be into a highly informative negative test. And the way to do that is to find the mutation first. and you need to do that with somebody who has a higher risk for having it. That is somebody who has cancer. So this leads up to a dynamic of how do you go back to family? How do you talk to them about testing? What goes on in that area? So that was a surprise for her. But let's just say why. I want to know what her risk is. I want to accurately determine that risk. I could change her management, but genetic testing should be done. So when we go back to the family member, we explain that they are the key to the family and that they are the ones that will actually allow us to find that gene mutation if it is there. Remember, more than one gene, different laboratories, different way of doing tests. So we may not be successful in actually finding that. So I essentially told her we're going to pick on her cousin or pick on her aunt. We've already gone over this, so that's the most accurate testing strategy. So here's what her aunt's results were, and I just put mutation for M, and she's positive. And then what that allows us to do, without even knowing what's going on with Dad, is number one, have the right test, because we know where to look. We don't need to do a full panel, we need to do one small test, and then we can calculate the risk. Her dad's risk, because we haven't tested him, is 1/2. Her risk, because she's daughter of her dad, is another 1/2. And then even I can do 1/2 times 1/2 is 1/4 risk. Sometimes it gets confusing. In genetics, 1/4 chance is high. It's a high genetic risk. It's in her favor, 75% chance of not having it, but it still is a high risk. So as she goes ahead and is testing, she'll either find out, am I at the high level? Do I need to have all of those fancy tests that I've been talking about? Or am I at that low level and I don't need to worry about a screening at this point? So when we talk to people, we talk a lot about the social impact of the tests. And these are things that people are really concerned about. Now, there's a law that went into place in 2008. This is all of the people that were there signing this law. And what it essentially did was it disallowed the use of genetic markers, genetic information, genetic tests for health insurance and for employment. And it's called GINA, Genetic Information Non-Discrimination Act. And if I tell you that it took Congress 15 years to pass this, would we be surprised? No. But it's a pretty good law. It's actually a pretty good law. All the stakeholders around the table, the insurers were there who had issues, and it worked its way through. But it's really an important area for people to think about because there is some legality behind testing now. When we talk to people, we need to go over certain facts. So these are kind of the facts. One is it's not comfortable to go through genetic testing for cancer. Why not? You might have cancer in the family. You might have lost a loved one. You might be very worried about cancer. You might have cancer. Those things are uncomfortable. So we recognize that, and we realize that you need to work through, or the person needs to work through their underlying understanding of that. You might, if you're a very private person, lose that privacy. The woman that I talked to you about who had to go to her aunt, she lost her privacy. She had to tell her aunt, I'm going through genetic testing and I want to know what's going on. So there's things within the family that are then known. And sometimes people are uncomfortable with that. We've already talked a little bit, and I will talk a little bit more about discrimination. Family dynamics might change. If there's a group of people who are positive and a group of people that are negative, and I have some stories about that you might ask me about later. The idea of being stigmatized is really key. In my mind, what that means is that people behave differently towards you on the basis of the gene test or the basis of a family history. And that's something that GINA discusses, but can't necessarily control. So that's an issue. Other issues that we have to talk about is how good is the test? I just told you there's a test that's this big, there's a test that's this big, there's a test that's this big, different laboratories, and not all laboratories may do this exact same job. Not all mutations are findable, and that's a technological problem. Some of the variants that are found may not have a clinical impact. We may not know, and those are called variants of uncertain significance. And then again, as I described with this family, that we needed to really think about what a negative result would be, and we needed to do that in the context of the family. For all of genetics, if you have a genetic marker that puts you at risk and you have certain management and therapeutic options, we don't know right off the bat if those therapeutic options will work or not. Now with BRCA1 and 2, we have a lot of knowledge about that now, and there's numbers of things that have been done. So here I'm just back to GINA. I just want to show you the fine print in GINA, and that is that it is for healthcare, it is for employability, it is not for mortgage insurance, car insurance, life insurance, okay? It also doesn't cover everybody equally, so there's some issues about that. And it also doesn't say that the health insurer has to pay for it. It might be part of your plan, it might not. It just means that you cannot be denied coverage on the basis of that. But if you and your employer have elected a plan that doesn't cover it, that is a difficulty. It doesn't apply to members of the military or the federal government. As other types of employment law do not. And then for very, very tiny employers, less than 15 individuals that they're employed, this does not cover. It does not apply. So if I could just take 30 more seconds of your time, I know I'm probably running a little bit over. I just wanted to let you know that the reason why I did come to Vanderbilt was to start this program and have an academic focus as part of the Vanderbilt Ingrid Cancer Center to provide both the clinical activities and to think about what risk means for patients and their families. So we are getting started. Here is a way to get a hold of us. What happens is you call a number. They make an appointment with you with one of our genetic counselors on the phone, go over your family history, and then they'll make an appointment for you to come in face-to-face if you think it's a good idea for you to come in. And then here's my beautiful group and their smiley faces. And then I'm going to thank you very much for your attention. And if you have questions, thank you. Okay. Yeah. Mm-hmm.
If you want genetic testing, all the research you have,
This is a really good question. It's if we can't go to another family member for testing because they're no longer here, they've died, then what we do is we go through the process of testing, and then that negative test is not as strong. I have a lot of caveats with the negative test, but a positive test is very positive. There is some. No?
On that very first slide, you talked about a non-malignant tumor getting malignant.
Mm-hmm.
How frequent is that?
How frequent is that? Oh, she's asking about the process of going from benign to malignant and the frequency of that. The frequency actually is different from different tissue types. So one example people often give is a colon polyp that is totally benign to turning to cancerous. They think it takes about 15 years for that to occur. And if the polyp gets to be over a centimeter, which is about half an inch, if the polyp is that size, it has about 30% chance of going the whole way.
I have a non-malignant tumor.
Mm-hmm.
I've had it for over 15 years.
Right. So it depends on the tissue of that particular non-malignant tumor. Many benign tumors, that's all they're going to do. They're not going to transform and go forward. Mm-hmm.
Are there identifiable genes related to lung cancer that you can test?
The question was identifiable genes for lung cancer. The answer is yes. They're very rare, but we actually have a project specifically looking at that within our group and with the lung cancer group at VICC. What we know is that it's familial, so lung cancer is familial, and that there are some genetic markers that people are looking at. The story is not as well developed as it is in breast cancer.
I hate to do this, and I know I'm going to get something really
I'll
hard
be here.
thrown at me.
Thank you very much.